We have Dr. Deighan.
Deighan this afternoon, Lord, yes.
Good afternoon, Dr. Deighan. As you appreciate, you're about to be asked questions by Mr. McIntosh, who's sitting opposite. But first, I understand you're prepared to affirm.
Yep.
Sitting where you are, can I ask you to repeat these words? I solemnly, sincerely, and truly
I solemnly, sincerely, and truly
declare and affirm
declare and affirm
that I will tell the truth,
that I will tell the truth,
the whole truth,
and
nothing but the truth.
nothing but the truth.
Thank you, Dr. Deighan. Now, I don't know how long your evidence will take. It might, we've scheduled you for the 2 hours between 2 and 4. If, on the other hand, you wish to take a break at any stage, please feel free to give me an indication and we can take a break. The other thing I would say is perhaps when you're answering questions, maybe speak a little louder than you would in normal conversation. The microphones are there to help, but for those hard of hearing like myself, I appreciate a little bit, just a little bit louder than you might speak in normal conversation.
Will do.
Thank you. Now, Mr. McIntosh.
Thank you, my Lord. Dr. Deighan, if I could take your full name and your current occupation.
Christopher Deighan, and I'm Medical Director for NHS Lanarkshire.
Thank you. Did you produce a statement?
I did produce a
Are
statement.
you willing to adopt that as your evidence?
I am, yes.
Thank you. Now, what I want to do is focus on a role you held at Greater Glasgow between June 2019 and January 2023. I understand that was as Deputy Medical Director Corporate.
That's correct, yes.
Could you perhaps assist us by explaining what a Deputy Medical Director Corporate does, or what you did as your general role?
Yeah, so I was a deputy to Dr. Jennifer Armstrong, who's the medical director in Glasgow and Clyde. And as the name suggests, my role was related to corporate and strategic issues rather than operational issues primarily. So I was involved with staff governance, clinical governance. I chaired our eHealth strategy board. Latterly, I was Deputy Responsible Officer, and I was also involved in supporting medical education and realistic medicine, and those were, and so they're like planning as well, corporate planning as well, and that was kind of the portfolio that I had.
Now, we have just heard this morning evidence from Dr. David Stewart, and he was Deputy Medical Director until just before you arrived, and it may help our understanding if you can compare your responsibilities to him. Are you in some sense a replacement for him? Or?
Not exactly. So when Dr. Stewart retired, his post was split into 2, and there were 2 Deputy Medical Director posts appointed at that point. There was the Deputy Medical Director Corporate, which was the post I had with the portfolio that I have described. And then there was the Deputy Medical Director for Acute Services, which was a separate appointment, which Dr. Scott Davidson was appointed to.
That's very, very helpful. Now, what I want to do is just take you to a few, well, not many events in the areas this inquiry is interested in, mainly in 2019. Could we look at Bundle 1, Document 73, page 325, which is a minute of the gram-negative IMT from the 25th of June 2019. Now, we see from this minute that this is a minute of a meeting on 25th of June 19, chaired by Dr. Inkster. Susie Dodd is reported as being present. I think that's her last meeting before she moved to HPS. Sandra Devine is there. A number of clinicians are there, some managers, Mr. Hill, Mr. Redfern, Mr. Steele from Estate, Professor Steele's there, Darryl Connor from Estates, Annette Ranking from HPS, and we see you mentioned there as well before we get to Dr. Kennedy, and a number of more of treating clinicians. This wasn't your first IMT. You'd attended one in January to do with cryptococcus, I understand.
I had attended one in January, which, when I saw the bundles, came as a surprise to me because I had no recollection of the January visit at all, and that was obviously long before I took the role as Deputy Medical Director. To be honest, I've got very little recollection of this meeting, which looks as if it was about 3 weeks or so after I commenced the job.
Well, indeed, that's the thing. So the January one, as far as I can see from the minutes, is that you must have been there probably because of your clinical role in renal.
Yeah, and when I had the questionnaire to respond, that was my thought as well.
So this one, the reason I'm asking about this is because, as you say, it's only 3 weeks after you arrived. We've heard from Dr. Stewart how, on occasion, it would be Dr. Armstrong's practice to encourage him to go to IMT, sometimes with her and sometimes by himself. And he described how he would go to sort of take the temperature, to listen, to show support, various other things. What was your purpose in going to this meeting and the ones that follow?
For this meeting, to be honest, I don't have a clear recollection. I assume that Dr. Armstrong asked me to go to the meeting, as you say, potentially to take the temperature and to feed back, but I can't specifically recall if there was a specific ask in terms of going to that meeting.
So were you aware of her giving you any form of preliminary briefing or instruction about what it was that she thought was interesting about this IMT?
I don't have a recollection, sorry.
Now, at an IMT like this, as a deputy medical director, what's your role in a meeting of an IMT of this sort? And how does that distinguish from your role in the January one?
So I don't think I had a particular role at the IMT, apart from feeding back to Dr. Armstrong. I only attended a limited number of the IMTs, and most of the IMTs I recall I probably attended when my colleague Dr. Davidson wasn't available. I think from recollection that I started in post before Dr. Davidson did, and therefore that's why I attended this meeting. But there wasn't a specific role or remit for me at the meeting.
So one of the things that's important to the inquiry about this meeting, if we can go on to the next page, is a discussion at the top of the page about there have been 2 cases of Mycobacterium chelonae in the hospital in the previous 12 months, and the redacted section is details of the patients involved. And then in the middle of the page, we have 2 paragraphs about Mycobacterium chelonae. Would this probably be the first time you come across this microorganism in your practice?
As far as I can recall, yes.
Yes. The reason that there's a discussion in these 2 paragraphs reporting that there have been no pediatric cases reported within the past 10 years, 2 cases in the last 12 months. There's a discussion of what Annette Rankin is due about acquiring some data, and that Mycobacterium chelonae has been added to the infection control alert organism list. And then there's a discussion about whether any other health boards currently test for the organism. You see that in the second section. Now, if we go on to the next page, it's other matters. We go to the page after, we see in hypothesis, where we understand that there's a discussion at this meeting about whether the drains were contaminated. Is that something that rings a bell with you?
Only when I was reading the IMT minutes.
Right. But I noticed that you are recorded as an action point with Mr. Hill to take forward at executive level whether other hospitals sample their drains and if any clinical cases have been reported within England. Why might you and Mr. Hill end up dealing with this issue?
I don't know the answer to that, but it wasn't something specifically I ended up taking forward.
Right. You think it might be something Mr. Hill might have done if it was done at all?
I assume so. Potentially it might have been Dr. Davidson, but it wasn't an action that I ended up taking forward.
Okay. So it's got to be, and if you go on to the next page, do you see how at ASCB, Professor Steele asked if he should inform Edinburgh Royal Infirmary, who are about to open a new hospital, which is also within the remit of this inquiry, to test the water before opening. And then the next sentence is, it was agreed that Dr. Jennifer Armstrong will take this forward about informing the executive management. I take it in Lothian. Would you have been involved in, as it were, having Dr. Armstrong volunteered in this in this way, which seems to have been recorded here?
Extremely unlikely that I would have volunteered my new boss to take something forward, if I'm going to be honest.
Do you think it's more likely that Professor Steele would have volunteered?
I can't answer that.
You can't answer that question. Right. The reason I've asked you all these questions is because this is the second case of Mycobacterium cheloni that at this point people are aware of in the Children's Hospital in a year. It's something that you will later come on to do a piece of work on. And at this point, what was your state of knowledge about what was going on in about Mycobacterium cheloni in the hospital at this point in June?
I don't think I had any detailed knowledge or awareness at all. As I said, at that point, I was about 3 weeks into the role.
Because I put to Dr. Stewart this morning the idea that, well, to ask him what effect it has on an IMT having senior clinicians and managers who aren't directly responsible for the unit involved attending IMTs, and he gave an answer. What's your view? What effect does it have on an IMT to have people like yourself, Professor Steele, others, senior people, even Dr. Armstrong occasionally, at the meetings? What do you think it has as an effect?
To be honest, I'm not sure.
I mean, there's two versions, which could be that it shows the members of the IMT that people take the matter seriously, and that the senior management are interested. That's one option. The other option is it might cause some people to be a bit more reticent or nervous because senior people are around. How would you comment on those two possibilities?
I think both of them are distinct possibilities. It might depend upon the personality of the senior manager and how well they know people around the table. But yeah, both are possibilities.
Because the way that I appreciate you're doing this from a limited amount of memory. The way that you seem to be describing your involvement in this meeting is you're just new to the job. You've turned up. You don't remember the meeting, but you're suspecting you didn't know about the background to Mycobacterium cheloni, and this IMT has been going on for a bit. Do you feel it would be helpful to be better informed when you arrive at these IMTs?
I think it would depend upon what the specific ask of attending the IMT would be, but I think so. Yeah, I think it would depend upon what the specific ask.
But in this case, you can't remember what the specific ask is. No. The Now, we'll come back to what you knew about this particular case and these two infections when we come back to your review. What I want to do is to move on to a follow-up IMT, which you weren't at, but which you might have seen the minutes. Is the next IMT, which is on the page 330. And this one is a meeting where Scott Davidson has attended, so this may support your conclusion that you're there previously as a substitute for Scott Davidson. Do you see he's on the second list, second name on the attendance list?
Yep.
In this meeting, there is a report that Kevin Hill, and it's on page 310. No, not sorry, that's the wrong page. It's on page. So I'm going to have to just check something. Yes, on page 333. Do you see under duty of candour? Professor Gibson is speaking to the most recent M. cheloni parent patients on Tuesday. And the next sentence, the chairman of NHSGC is in communication with the father of the first case. So, what is that something you remember being told at the time, knowing at the time, or it only comes up in your review later because you weren't at this meeting?
I wasn't at this meeting, and it's not something that would have been on my radar at all.
Okay. What I want to do is to look now at the next meeting you attended. Now, the next meeting you attended, I understand, is the 14th of August, and that is Bundle 1, Document 77, page 343. So this appears to be a meeting on the 14th of August. Again, it's chaired by Dr. Inkster. It has a slightly larger attendance this time. You're present. And the issue in the meeting is you'd not attended the previous two meetings, and Scott Davidson had. And I'm wondering what your practice was on ensuring that you were up to date when you go to these meetings. Would you have read the minutes? Would you discuss them with Mr. Davidson? Would you have found out Dr. Davidson found out other ways?
I don't recall.
Do you have a practice when you go to IMTs about finding out what's happened?
I really don't recall. I wasn't a regular attendant at the IMTs, and I don't recall.
Yeah, I appreciate that now, but I mean, if you are a deputy medical director corporate, you're going to an IMT, it's a complicated meeting. I think you'd agree with me about that. You're sort of blinking in a sort of vaguely approving way. Would you agree it was complicated?
Oh, 100%, yes.
Right,
yeah.
now, because the transcript doesn't get your gentle head gestures, we do need you to use words. Would you accept that it's unlikely you would have gone to an IMT without doing at least a small amount of preparation?
So the minutes of the previous IMT will have been sent out as papers for it, and therefore minimally I would have read the minutes of the previous meeting, so I was up to date. And also it's recorded in this meeting here reference to a paper that I'd read from Dr. Ian Kennedy.
Yes, because he raised that at the previous meeting.
And so clearly I'd read that paper
Yes.
in advance of the meeting as well.
And in this meeting on the 14th of August, are you aware of there being a pre-meeting for any participants in the IMT?
Not that I can recall.
And so we know that there's a subsequent meeting which you're not present at, where there seems to be quite a lot of evidence that was a pre-meeting beforehand.
Right.
And we're still talking to all the participants. So the reason I'm asking is because had there been a pre-meeting of the one that I mean, seeing if it happened, you were likely to be involved in it, but you don't recollect there being a meeting, or you don't know.
I really don't recall attending a pre-meeting for that one.
Now, if we go to your statement, page 160. If we go to the statement bundle, please, page 160. The minute of the meeting, which we'll go back to the moment. So we go page 160. No, that's definitely the wrong bundle. That's from the last hearing. So while this is coming up on the screen, Dr. Deighan, effectively what I'm going to try and do is I'm going to put to you what's in your statement, but you might want to go back and look at what's in the IMT minute before you answer my question. So that's an opportunity there. So we go to the statement.
I've got my statement in front of me here.
I know, but it's the audience
Oh, sorry.
sitting to my right who need to see it. So you're looking for the statement bundle, page 160 from this week, Tom. Yes, that should be the right one. No, that's the wrong one. That's looking for a previous statement bundle. This is Dr. Kennedy's statement. So it's the statement bundle for this week. While you're doing that, I'll set up the question with Dr. Deighan. So what I have taken is two things. So in the IMT minute, which we'll go back to and look.
Can I just interrupt? So just to make sure that everyone knows what you want them to be doing. The last note that I have of what you said, Mr. McIntosh, was referring to Dr. Deighan's
We have it, my lord.
witness statement. Was that what you were?
Yeah, that's what I'm looking for,
Right,
and
fine.
I'm grateful to my
Fine.
colleague
I'm
who's now
glad I'm
produced it.
keeping up. I just wondered if you were wanting something else.
No,
from
I've
us.
got what I wanted, and page 160 was there a moment ago.
Yeah.
Perfect. So, what we have halfway down this page, well, at the top of the page, we have IMT 14th of August 2019, and you say you recall attending the meeting, and you describe the purpose of the meeting by reference to the document itself. And then at 29, it states, I think in the minutes, it should say, in the minutes, you're reported to disagree with Dr. Inkster that the number of bacteria may have increased. And we ask you, what is this opinion based on? Please provide reason for your conclusion. Have you since changed your mind? If provide reasons for it. And then you've answered, as noted in the minutes of the meeting, I referenced an epidemiology report from Dr. Kennedy that I had seen. And there's nothing in the minute just I disagree with Dr. Inkster. The minute notes that my comment was in response to a comment from one of the consultants and would seem reasonable to seek clarification. The minute goes on to note that Dr. Inkster and Dr. Peters went on to state that is the nature of the bacteria that was a concern. It's likely that CLABC work and excellent practice have driven rates of typical pathogens down. Now, if we go back to the IMT bundle, bundle 1, page 343, and then if we go to the section we're talking about, which is the middle of the next page, I think what might be the point that we should have been making to you is this. It seems to be a possibility that there was some, I hesitate to use the word disagreement, but some lack of entire agreement about what was going on at this point. And that Dr. Kennedy's report and you in this minute seem to be suggesting that there's no increase in infection numbers. And Dr. Inkster is raising the possibility that whilst there has, that in some way there's been a reduction caused by CLABC and practice. Do you remember why it was that you raised this issue in this meeting, the Dr. Kennedy report?
So, as the minute notes, one of the consultants, according to the minute, said that there'd been an increase in infections. The information I had at that point clearly was based on the report by Dr. Ian Kennedy that I'd read, which had suggested that there wasn't an increase in infections. In response to that, Dr. Inkster and Dr. Peters, according to the minute, clarified that it was the nature of the bacteria that was a concern. I'm not sure, and I don't recall there being a disagreement there. I think what I was looking for was clarification based on the knowledge that I had at that point in time, following the comment from one of the consultants.
Thank you. At this point, Dr. Kennedy's paper, which we can go to if we need to, has been produced, the 2019 version, which has the 2018 version as an annex. So you presumably saw the 2019 version with the 2018 version as an annex to it. Does that sound right to you?
I haven't seen Dr. Kennedy's paper in a number of years, and therefore I wouldn't be able to specify. I can only reference what's in the minute rather than anything else.
Because at this point, there are other epidemiology bits of work out there. There are two HPS. There's one HPS piece of work particularly from early 2019. Had you seen that?
I don't recall.
So this is just a question based on the paper that you've got attached to the previous minutes, in essence.
Yeah, so it's seeking clarification following the consultant's comment based on the information that I had at that point in time. And when I sought clarification on that, then Dr. Inkster and Dr. Peters responded as is in the minute. That would seem to be what
so the impression that they have formed, and Dr. Peters has given evidence and Dr. Inkster is still to give evidence, is that this point that you've raised is not dissimilar to a point raised with Dr. Inkster a few days before by Dr. Armstrong. And so I have to put it to you, would this have been something that you discussed with Dr. Armstrong in advance of the meeting and sort of come ready to make as a point?
I honestly don't recall.
Because this meeting is the last paper IMT you attend before Dr. Inkster is removed as chair, isn't it?
So I think I only attended 3 or 4 IMT meetings. I'd need to go back to my notes to see exactly when they were and the timing of the change of the chair, but I think that's correct, yes.
Right. So what I want to do is to look at an email that you received on the 16th of August 2019. That's Bundle 14, Volume 2, Document 144. At page 568. So this appears to be an email from Ranjit Bajway, who I think is the support person for Dr. Armstrong or Dr. Castecker, I can't remember, to a series of people, including you, inviting them to a meeting on the 20th of August at 3 o'clock in the Learning Teaching Room, the subject of which is hemato-oncology, assessment of current position and understanding additional support requirements, albeit this may be a forwarded email, so that may not be the original, that may be an original subject from a previous part of the thread. And you see the text, dear colleagues, as you will aware, there are a number of issues regarding the hemato-oncology unit at Queen Elizabeth University Hospital. I'd like to take this opportunity to write you to a meeting, discuss these issues. The aim of the meeting is to set out the current position. I don't know why the T's have disappeared, and discuss additional support to address current issues. I'm aware this is a short notice for this meeting, and I ask you to flex your diaries to accommodate the meeting. I will chair the meeting. The meeting will take place, and it gives the time and place. Now, when you receive this email, firstly, do you remember receiving this email?
No.
No. From this email, what would you understand the purpose of this meeting was to be?
Exactly what it says in the tin. Being invited to a meeting to discuss a number of issues regarding hemato-oncology unit at the QE. I'm not sure I would necessarily read into it any more than what the email says.
Right. And you don't remember receiving this email?
I honestly don't know.
No. Well, let's look at the meeting minute. So that's Bundle 6, Document 22, page 70. So this is a meeting on the same day, albeit described as being in the boardroom, and it has the same attendance list as the invitation list that we've just seen in the previous email inviting people to a meeting on 20th of August, albeit Dr. Inkster has given her apologies. Do you remember going to this meeting?
I do remember going to this meeting, and I remember it because up until June of that year, I'd been Chief of Medicine at Glasgow Royal Infirmary, and I remember it, I think it was probably the first time I'd been back in the management area at GRI since I'd taken on my new job, so that's specifically why I...
Yes, so you're still going back to your old haunts?
Yeah, absolutely.
Now let's look at the people who are present. I want to just make sure, at this point, is there anybody at this meeting who you wouldn't have met before this meeting?
I can't recall whether I'd met Mr. Forrester before or not. I may have done, but the rest of the names would all have been familiar to me at that time, yeah.
And if we look at this list, I've checked across, and I'm happy to go back and check, but 5 of the attendants at this meeting have been were at the IMT on the 14th of August. That is you, Sandra Devine, Jamie Redfern, Jennifer Rogers, and Professor Steele. And Dr. Kennedy had, as you already mentioned, been at an earlier meeting. But Dr. Mathers hadn't attended one since January. And I wondered if you knew whether Dr. Green, Mr. Best, and Dr. Maguire had attended any of these gram-negative or cryptococcus IMTs.
I
You can't help me, right? And you see that Dr. Inkster gave her apologies.
according to the minute,
Do,
yes.
do you remember her being there or not there from your point of view?
I honestly don't remember.
Right. Well, let's look at the background. Professor de Keestecker opened by outlining the purpose of the meeting as considering recent experience of IMT meetings, the appropriateness of using this mechanism to manage the complex issues which are ongoing in the Queen Elizabeth University Hospital, and identifying learning from experience might be beneficially applied to resetting the IMT process. Professor de Keestecker reminded the meeting that national guidance states that the Director of Public Health has a role in reviewing the functioning of IMT if there are any concerns. Now, my first question is, to what extent do you think the background and subject of this meeting is properly indicated in the invitation that we've just looked at?
Sorry, I'm not sure if I follow your question.
Well, let's go back to the invitation, which is on page Bundle 14, Volume 2, page 568. This appears to be the invitation to attend the meeting that was sent to Dr. Armstrong, Dr. de Keestecker, you, Sandra Devine, Rachel Green, Dr. Inkster, Ian Kennedy, Margaret Maguire, Jamie Redfern, Jennifer Rogers, and Professor Steele. This invitation does not mention that the subject of the meeting is to be what has just been described in the minute as the background of the actual meeting that took place, does it?
It doesn't appear to be.
No. So, given that you can't remember receiving the email, looking at it now sort of dispassionately from, 5 years on, if you received this invitation and then turned up to the meeting that's described in that minute, would the subject come as some form of surprise to you?
Not sure.
Well, this meeting doesn't, if we go back to the minute of the meeting, which is Bundle 6, Document 22, page 70, there's nothing in that previous email to indicate that the purpose of the meeting is to discuss the appropriateness of using IMTs to manage the complex issues ongoing at the hospital, is there?
That would appear correct, yes.
And there's nothing about identifying learning from experience that might be beneficially applied to resetting the IMT process, is there?
That would also appear to be correct, yes.
In fact, there's no mention of IMTs at all.
Not in the email, no.
Now, we can hear from Dr. Inkster, I'm sure we will, about why she didn't attend this meeting. Now, if we go and look at the rest of the meeting, issues of concern, and stop me at any point if you think the minute's wrong from your recollection, because obviously you went back to your old haunts. First time you're back there, you're in the boardroom. Professor de Keestecker invited those present to give feedback on their experience of IMT meetings. At this point, you've been to three.
Well, it depends whether you count the one I'd been in January, which was that with a separate
I was
one.
being generous. You've been to 3.
Okay.
Yes. And so, do you feel, or did you give any substantive feedback at this meeting?
So, as I've said in my statement, I recall feeding back relating to the one of the rooms. So the first meeting I was at, which was the one in June, I think I noted in my statement that the set out of the room really wasn't conducive to having a meeting with a small table and people being scattered around the room. And to be honest, that's my overriding memory of that meeting rather than the content of the meeting itself. The only thing that I recall feeding back about the second meeting wasn't related to the comment about the infections which you noted earlier, but was related to behaviours, which again I've noted in my statement.
Okay, so actually we can see in the second sentence, 2 themes of feedback were raised: practical issues relating to membership, room, which I'm assuming to some extent must have its origin in you, and then behavioural issues in recent IMT meetings, which you've just explained as one of the things you might have mentioned. And then the group, I'm assuming the group is the people at the meeting, also highlighted the need for an IMT to work within a safe and confidential environment in order to manage the situation and protect the patient confidentiality. And then this discussion of press leaks. Have you been aware of press leaks at this point?
I may have been aware of them. I can't remember any specifics.
So the thing that's interesting to me is this meeting doesn't appear to have as its membership all the members of the IMT. They're not all being consulted, are they, Dr. Deighan?
Well, certainly the chair of the IMT is not being consulted, because the chair of the IMT at that point was Dr. Inkster, and she's clearly given her apologies to the meeting.
Well, she hasn't, has she? She's given her apologies to a different meeting, because she's not been told this meeting is about the IMT, has she?
Well, she's got. Well, I'm not sure I can comment on that.
Okay, well, let's make it about you instead.
Yeah.
Let's imagine that you had been chairing a series of meetings in one of your many jobs in the hospital, and an invitation had been circulated by senior managers inviting you to discuss something completely different, and you had given your apologies for some other reason. We'll come out with that. And then you discover later, when you get the minute, that they're discussing you and your conduct. How happy would you be about that?
If it was me, I would not be happy. Yeah.
Because one of the things that interests me here is you're not someone who had a lot of experience with this IMT, are you?
Nope.
Because if we look at the other people here, Professor Steele has been to lots of these IMTs, as has Mr. Redfern and Miss Rogers and Miss Devine and Dr. Kennedy, and they appear in many of them. So they have some experience to contribute to this discussion. But you have a limited experience because you've only been to 3 meetings. You'd agree about that?
Oh, yeah, absolutely.
Yeah. So you're the Deputy Medical Director Corporate. How do you feel about a meeting being held to discuss one of your senior clinicians, of which they have not been given practically any notice that they are the subject of the meeting? Do you feel that's suitably respectful of a colleague?
I can certainly see how it might be viewed.
Viewed as what?
So if the discussion was centred around me and a series of meetings that I was chairing, then I could see that I would be unhappy in that context.
Because one of the obligations on a doctor is to be respectful of your colleagues, isn't it? Is that a yes?
That's an absolute yes.
Yes. And so you'll be familiar with the idea that whilst the person who calls a meeting in many ways is very responsible for what happens at the meeting, people who just go along and sit quietly are also responsible for what happens at meetings, aren't they?
I think that is correct, yes.
So in a sense, you, and I accept, completely new to this environment. You've not lived through the last 3 or 4 years. I mean, we've been talking to about and to the people listed on this meeting for some time in this inquiry, and we will hear their stories in the next few weeks. You're new to this.
Absolutely. So the meeting's on the 20th of August, so I've been in post for a couple of months.
So at one level, I'm being slightly unfair to you. But I do have to put to you that, is it really proper for a bunch of doctors and nurses to hold a meeting to discuss the then lead infection control doctor's conduct of her meetings without giving her notice and in her absence?
So I can certainly see the argument that you're putting forward. I think that question probably needs to be directed to the chair of the meeting that called the meeting rather than myself in that circumstance.
Because I think I will direct this question to you as well, and I'll direct it, if I remember, to everybody else who's still to come in the witness list. But is there not some obligation to have said, once that opening had been delivered, excuse me, I didn't get an invitation to that meeting. I thought this meeting was at issues in hemato-oncology.
So as previously noted, I don't recall the email, and therefore I don't recall the context at which the meeting was called.
Now let's go through the rest of the minute. So we've discussed the big paragraph after issues of concern and the concern about press leaks. And then there's an observation regarding practical issues. Those present raised concerns regarding the number of people who are present at IMT meetings and the uncertainty as to who might attend and the coming and going of the people once the meeting is underway. And then the room issue is raised. Now, and it ends the page. It was noted that guidance for IMTs provides required attendees, discretional attendees, and who may change depending on the nature of the issue. It was noted that one role of the chair, over the page please, would identify who should attend and who's required for any particular discussion within an IMT. You've obviously only attended a few IMTs at this point. Do you have any thought about whether it helps the IMT process to have additional senior people attending those IMTs, or whether you think it's a benefit?
So my thoughts would be that you should have a consistent core participant so that there is a regular thread throughout the meetings, but that you may on occasion want to invite additional people if they're presenting specific areas or linking in with specific issues that arise.
The next paragraph deals with behavioral issues, and it describes, in the first sentence, those present raised concerns regarding the nature of communication with the IMT. Confrontational, uncomfortable dialogue, off the scale bad, totally disrespectful, inappropriate language. Putting aside whether it's totally disrespectful to discuss the IMT in the absence of its chair, are you aware of whether anyone in this meeting had taken the soundings of the other members of the IMT who weren't present at this meeting?
I'm not aware, no.
Now, the last sentence, it had been reported that some people felt unable to speak up at the IMT because of this culture. Can you recollect whether that is discussing the views of the people at the meeting or other people who aren't at the meeting who are perhaps being reported back?
I don't recall. This meeting was 5 years ago, and I simply don't recall.
The rest of the meeting discusses a potential way forward. And you see the third paragraph, consideration was given to the benefits of holding a small group pre-meeting to ensure the chair is fully informed of the circumstances, is prepared for chairing the IMT and consider discretional attendees. Are you aware of whether that's consistent with the National Infection Prevention Control Manual?
It's not my area of expertise, and therefore I wouldn't be able to make an informed comment on that.
Right. And then the actions. Now, am I to take it that everybody at the meeting would have agreed to these actions?
I don't recall.
Well, you're not minuted as disagreeing, Dr. Deighan. Should we take it from this that at the end of this meeting, if I'd asked Dr. K-Secker, did everyone agree, she'll say yes? Or do you think you've dissented in some way?
I honestly don't recall.
There seems to have been a decision made to change the chair of the IMT process to an experienced public health doctor or an ICD for another area. Do you remember that?
It's noted in the minute. As I said, the meeting was 5 years ago. I'm heavily reliant on reading the minute to have recollection of the meeting.
So I'll come back to that bit in a moment. What I want to do is move on to talk to you about your review. But before I do that, I think we'll just touch one IMT, which I didn't give you notice for, but I want to give you an opportunity to explain something that I realise I don't understand, which is Bundle 1, Document 83, page 371. It's October. And I was reading this again, 371, and I realised if we go on to the... We go on to page 373. This is an IMT after the chair has changed on the 8th of October. And there's a large attendee, so they obviously haven't got on top of the attendance problem by this point. But on the second page, there's a discussion about the definition of a hospital-acquired infection. I recognise I'm bouncing this on you, but do you have any recollection of this discussion?
Vaguely.
Because what I'm trying to understand is, I get the impression that your perspective is that of a nephrologist or a renal doctor.
Yeah, I had read this because it was noted in the questions from the questionnaire to start off with, and yes, I'm presenting here my experience from a renal clinician perspective, because infections in dialysis patients is something that we track on a regular basis.
Yes, and indeed somewhere within this section you observe that they're actually at a slightly higher risk of infections than some other classes of patients.
Certainly the presence of dialysis access and plastic lines in the necks of dialysis patients gives them a propensity to infections in addition, added to their comorbidity.
And the thing that intrigues me about this intervention is, and I may be corrected by other witnesses or indeed possibly my colleagues when I finish asking this question, is that it seems that what's happening is that there's an attempt to create almost a bespoke definition for cases at this point in time to understand something that's going on at this point, and that you're commenting that's different from national policy for dialysis patients. Does that seem roughly right?
Yeah, I think the point I'm making here is if you change the definition, then you negate the ability to compare your rates with rates elsewhere because you're no longer comparing apples with apples.
Well, that seems a very sensible point. But I suppose the question to ask back is that at this point, we are now October, and this is about the time when the health board gets taken to stage 4, and there's lots of senior people involved. I think Professor White's attending these meetings at this point. It occurs to me that your observation comes with the weight of authority of the Deputy Medical Director, but actually it's really the professional opinion of a long experienced nephrologist.
And I think the minute notes that to an extent.
No, I think it does, yes.
Because it does say, although he was happy to be corrected on this by his hemato-oncology colleagues, and therefore, I do, the minute notes that I'm talking about hospital hemodialysis patients.
Yeah.
But I can totally, acknowledge what you're saying in terms of, sometimes the role brings with it a certain level of gravitas, and I think we always need to be aware of that.
Well, indeed. And so I think the question I'm making is, might there be an issue in the way that IMTs work or were working here, that senior people are there, they are showing the hospital's concerned, they are asking questions, but occasionally, because of their own experiences, their own professional background, they sort of have the potential of slightly influencing stuff that they wouldn't have been influenced if the medical director had been an A&E doctor or something. Or am I making him something out of nothing?
Well, I think, as I said, I'm reading this on the go, but I do, the minute does note under point 3 there at the bottom of the page that I'm specifically referring to hospital-acquired infections and hospital healthcare-associated infections, rather than the definition of an outbreak of an IMT, which is something completely different. And there's a clear definition of a hospital-acquired infection and a healthcare-associated infection, rather than the group of infections that are being followed up by the IMT. And I'm specifically making that point.
Thank you. Well, that was helpful. I just wanted to clear that up because it confused me. Let's go where we were mainly going, which is back to your review. So if we go to Bundle 27, Volume 6, Document 6, page 91. This is a report by you from May 2021.
Correct.
Yeah. Now, I want to ask you quite a lot of questions about this. So what I thought we should do is take a moment just to walk through it, just so we can remind ourselves of the sections,
Yep.
and then I'll ask you some questions. And then I might come back to something from the previous topics. So can you explain how this report from you came about?
Yes, so as it says in the background, at the beginning of October 2019, Dr. Armstrong emailed me regarding the three issues that are raised there, which had been raised by Dr. Ingster in her letter of resignation to Dr. Armstrong. And Dr. Armstrong, subsequent to that, asked me to take forward a review of these three issues.
And the fact that it took you a year and a half has probably got something to do with the pandemic, I'm assuming.
And that, to be honest, made the completion of the review really quite tricky, simply because the COVID pandemic, hit in February, March of that year. All sorts of things changed at that point, and then by the time it came to completing the review, as is noted in the substance of the report, a number of things had taken place, a number of changes had taken place.
Indeed, and so what I wanted to do was let's just look at the three, just make sure understand what the three issues were. So the SCI process, that's a significant clinical incident.
Yes.
And that relates to Cryptococcus neoformans and the death of a patient.
Correct.
Or two patients, in fact. I think the SCI might only have been about one.
So the SCI was about one patient.
Yes. The duty of candour regarding infection control incidents, now that relates to a duty of candour issue raised by Professor Cudahy.
That relates to communication to Professor Cudahy regarding an infection control incident, yes.
Right. And then the governance issue, in very short terms, relates to an issue about whether the group working on addressing the problems of the water system should or shouldn't have reported in some way to Dr. Ingster. That's a very shorthand version of it, but it's roughly that.
No, it primarily related more to Dr. Ingster's concerns about specific actions not being followed, and the link between the water technical group and the IMT, and really the governance of decision making within the broader IMT and water technical group.
Right. Now, and then in the next paragraph, we see that you report that you asked Dr. Green, Chief of Medicine and Diagnostic Services, to interview Dr. Ingster to get a fuller account of these issues. The interview took place on the 6th of January 2020 and is detailed in Appendix B. I might go to that in a moment, but before I do that, I think I could probably usefully go to the invitation to that meeting, which is in Bundle 14, Volume 2, page 509, document 128.
That's not that one.
So one of the things that has arisen in Dr. Ingster's statement is that she didn't realise you were doing this review. That's her position in very short terms. And this is the invitation that I recognise you didn't send this. It may be that it's simply a confusion has happened. But do you see how the invitation says, Chris has asked me to meet with you to investigate some concerns you have regarding those three issues. So do you see how it might appear to Dr. Ingster that it's Dr. Green who's carrying out the investigation?
Yeah, I can see how that would appear, yes.
Because actually by the time you finished the investigation, Dr. Ingster has moved on to NSS. Yes. Now, if we go back to your statement at page 173. We'll go to 172, actually, we'll get a better answer. Do you see question 73? You asked about the review, what were the key factors considered and why? Now, you clearly think this paragraph's important because you reference back to it later on, and I wanted to understand what you're trying to say. So your answer is, this was not an investigation underpinned by any policy framework, rather a review of the issues raised. As noted, as such in section 4, summary report, which we'll go back to if we need to. Given the multiple investigations and inquiries that were ongoing, the key factor was to get clarity and fuller account of the issues raised under the broad headlines in order to provide a clear focus for the review. Now, in a sense, what's the distinction you're trying to make by saying, and you say it again in paragraph 75, that it's an investigation or a review of the issues raised rather than an investigation underpinned by any policy framework? Because I'm afraid I'm missing that.
Well, I suppose there are a number of investigations that have policy framework underpinning them. That, for example, a serious adverse events review, or an SCI review, or a whistleblowing review, or an investigation related to staff governance issues. You know, there are plenty of investigations that can be done that are underpinned by policy frameworks. This was simply Dr. Armstrong asking me to review these issues and draft a report accordingly.
So it's not, in essence, it's an informal report is the point you're making. It's not part of any system.
I think that's absolutely right.
Right.
Yes.
Okay. Now, we go back to the report itself. So that's yes, to page 92. So the declaration, I appreciate you're writing this in May 2021. You report that you attended 3 of the IMT meetings, deputising for Dr. Davidson.
So, in fact, in retrospect, I'd actually attended slightly more than that. But
Yes, but 3 in the summer. You have others in October. Yeah. When, as a result, you were interviewed as part of the internal whistleblowing investigation, and you contributed writing of the letter from the board medical director to the parent involved in duty of candour incident. And you say that you worked with Dr. Inkster as a colleague in the past, and you've co-authored 2 publications in 2017. I'm intrigued to know why you don't mention your attendance at the meeting of the 20th of August at this point.
Clearly, I either felt that hadn't been important, or it's completely slipped my mind.
Because it might be, well, I think I have to put to you that you might not be the ideal person to write this report, because Dr. Inkster probably wouldn't have raised these 3 issues had she not resigned as a lead infection control doctor. And to some extent, the reason she resigned as lead infection control doctor, and she'll explain exactly the connection, because it may be health as well, is because she was removed as the IMT chair. So do you see that there may be a suggestion that you're actually probably the wrong person to be doing this from her point of view?
And that is the question about bias, be it conscious or unconscious bias, was flagged in the questionnaire that I was sent, and I can completely understand how it might be perceived that I may not be impartial in that context.
Well, indeed, because we've got to work out what weight to give to your report. And so what I want to do is look at the 3 issues at sort of top level and really try and understand what information you had available to you. Because I appreciate you didn't write this report with the idea that lawyers will be asking you questions about it 3.5 years later. So if we look at the section on the SCI process, what were your conclusions on this particular issue?
So in terms of the SCI process, I specifically asked Mr. Andy Crawford, who was the head of clinical governance in GGNC at that point, to review the governance here, because in many ways, in the context of the 3 issues that Dr. Inkster noted there, I was asking myself, right, what's the exam question here? And the exam question really for the SCI process really was, was due governance followed, and was due governance appropriate? In the knowledge that clearly Dr. Inkster disagreed with the way that the SCI had been progressed, and had GGNC followed appropriate governance in terms of the processes.
So your section here, which is about governance and process, is to some extent grounded on this separate report by your colleague.
Yes.
Right. And what I'm concerned about is that we have the email exchange that takes place when the first draft of this SCI is produced. And we have Dr. Inkster commenting on how she's not, in short terms, happy with the changes. And we have the attached document with the track changes. Would you have had access to the original document with her comments on it?
So that was sent to me as an additional bundle late yesterday, and that's the first time I had seen it.
So you didn't see her actual letter, her actual complaint?
I was working on the narrative that she gave to Dr. Green when Dr. Green interviewed her.
Because
But what I
sorry.
would add,
Yeah.
what I would add is when I read that yesterday, it very much aligned to the feedback that she'd given Dr. Green when Dr. Green had interviewed her.
Because one of the points that you make at the end of your conclusion, and I recognise it may be more complicated than I'm saying it, is that you didn't feel that you could corroborate her complaint. Now, I suspect you might have mean confirm or agree or find out that it's true, as opposed to what we as lawyers would see as corroborate. What do you mean by that, as corroborate a complaint?
I think you're absolutely right there. So I wrote this report something like 3.5 years ago, and I've not seen it for 2 years. And you reflect on the language that you put in these reports. And when I read the report again, I think it's probably fair to say that the use of the word corroborate is probably not the correct at that point.
Because in some senses, your position, and in many ways there's nothing wrong with that, is that you disagree with her views.
So I tried to do a report that was detailed and narrative and took things through in a logical process, because in many ways that's the way my mind works. And basically the report said that I can totally and absolutely sympathise with and understand the view that Dr. Inkster had in the context of her feelings about the SCI, and also in terms of her feelings about the duty of candour. But I didn't feel that the findings of the report necessarily supported them. It was difficult to prove one way or the other. Yeah.
Well, can we go on to onto the next page of this bundle, which is page 93. Now, I'm interested in the second paragraph. I mean, there may actually be nothing wrong with we don't know really yet, with a corporate interest being taken about an SCI. That's something that I'm quite keen to hear what you have to say about it. But I do notice that one of the things you draw out is that there were organizational sensitivities. And so what I'm really trying to capture here is looking at it dispassionately from now backwards. Is it legitimate to think that an SCI like this should actually be, in a sense, under control of the IMT chair? Or is it better to take the view that this is something for the board as a whole at a sort of governance level?
So I think that's a very reasonable point. And if you go down to the last paragraph of page 93 there, it does highlight that subsequent to this, the revised SCI policy, or Serious Adverse Events Review Policy as it became known as, when it was updated, introduced a couple of processes in the update. If the first was corporate commissioning of an SCI, where it was felt that there were issues which would be not simply local to a service, but would be wider beyond that. And then secondly, a process that underpins resolution of disputes similar to was identified in this. So in fact, some of the learning from this SCI was embedded within the updated SCI policy, which was due for revision in 2020.
Might that not support the conclusion that at the time this SCI started life in 2019, whether it was right or wrong, the policy rather required this to be a local decision? And therefore, whether it's the right decision or not, to some extent, Dr. Inkster's right that this decision has been pulled from the local team up to a corporate level when the policy at the time didn't then require that?
So I think the issue about this SCI, the complexity of this SCI was, so this SCI was very complex to start off with, and was made more complex by the fact that separate to the SCI, an additional independent investigation into the source of Cryptococcus and the potential role of pigeons and ventilation was then put in place by the organisation, and therefore you could potentially therefore have two separate investigations running in parallel, which could conceivably come up with completely different conclusions. And therefore, given that the additional investigation was put in place, the view of Andy Crawford was that it was entirely reasonable to revise the terms of reference of the SCI to focus on the clinical care of the patient in Ward 4C, and to have the separate investigation which would be fed back to the family, looking at the role of ventilation. And in fact, I am aware of that, and I know that because I've seen correspondence which is in Appendix C of the report, which notes from the commissioners of the SCI that they have discussed this with the head of clinical governance, who felt that this was an entirely appropriate thing to do in the circumstances.
Thank you. The point that I suppose to wrap up this section is that if you have a incident where the issue is not practice in a ward or decision of an individual clinician or an error by anybody, but it is something to do with the very infrastructure of the hospital. It's a consequence, whether expected or unexpected, of a decision that was made years before at some vast expense. Then there is at least the suspicion that the corporate response, further you take it away from the experts, might want to protect the reputation of the organisation rather than get to the bottom of what went wrong. Do you see that as a risk about governance, corporate governance taking, shall we say, a lead, or at least a senior role in SCIs?
That is a risk, but at the same time, there's as I've said, if you've got parallel investigations going on looking at the same issue, then there is always risks that these parallel investigations then come up with completely different viewpoints and completely different output. And so in the circumstance, that is why the commissioner of this investigation, of this SEER, spoke to the head of clinical governance, who agreed that the terms of reference for this SCI should be revised to focus on the clinical care, because there was a parallel investigation that was ongoing.
Because, well, is that right? I mean, let's do a different example. Let's imagine a clinician makes an error in an operation and something bad happens to a patient. People who know about that piece of medicine investigate it, reach a conclusion, and that's a reality the board has to deal with. And no one would suggest that at that point a corporate investigation happens in parallel, would they? They would just rely on the individual investigation. Have I got that right?
Yeah.
Yes. So why is this different? Why is it that if somebody or some people or an organisation made a mistake in maintenance or procurement of a ventilation system many years in before, why does the organisation get to take over the process? It wouldn't do that if the organisation had hired a not very good doctor, would it? That would still be an issue for the local team to work out what had happened.
So, as I said, in this circumstance related to this SCI, there was an additional independent investigation that had been commissioned.
And this is what became Professor Hood's report.
That's what I believe they're referring to, yes. And therefore, given that additional independent investigation is ongoing, that was the rationale to revise the terms of reference. And in terms of, the remit of this review, I was asking myself, was due governance followed? And it appeared to me that due governance was followed, because at the end of the day, it's the commissioner that has to finalise and agree what the report is, and the commissioner of this liaised with the head of clinical governance, and therefore it appeared to me that in terms of the process that was followed for this SCI, that due governance was followed, whilst accepting that not everybody agreed with that. And sometimes, occasionally, that happens with SCIs. Sometimes there is not an agreement in terms of the output of an SCI, and the commissioner of the SCI has to make a call as to what they're going to accept for the SCI, which led on to the revision of the SCI policy to ensure that there was a procedure to underpin resolution of disputes.
I suppose the question that flows from that is, why do you think that the report of the Cryptococcus expert subgroup is an independent report?
It's independent to the SCI.
It's not independent of the health board, is it?
I think that's a reasonable point, yes.
And indeed, were you aware that NSS, its members, didn't agree with the conclusions and made that very clear?
I haven't seen the output of that report, and it's not something I'm familiar with. Again, looking at the wording of the report here, much of that, as I said, I asked Mr. Andy Crawford to look at this aspect of things. Independent investigation, is clearly referring to an investigation independent of the SCI, not necessarily independent to the health board.
I'm going to try not to take you through your statement because you give a very, very long answer. I'm going to put something to you that you said in your statement and see if you recollect saying it, and we'll work out what you meant. So within your statement, in answer to question 83, which is on page 178, please don't put it up, you observed that Dr. Inkster was invited to put any concerns that she had in respect to the final draft in writing to the Director of Regional Services, and no reply was received. And the report was signed off in April 2020 and shared with the family. Now, that's something that you were expecting. That did happen.
That's noted in Appendix C.
Yes. So, just to check, would the Director of Regional Services at that point have been Errol Williams?
Yes.
Yes. So Dr. Inkster's response to this is, by this point, she had raised the issue in her original email about the terms of the SCI, which you didn't see. She'd raised it in her resignation letter to Jennifer Armstrong. Did you see that?
I've not seen the resignation letter to Dr. Armstrong.
She raised it to Linda de Keestecker in the investigation, which presumably you wouldn't have seen the report from that. She raised it in an email to you, which I'm not going to put on the screen, but what I'm doing is I'll ask my colleague to sidle it across to you. It's on Bundle 14, Volume 2, Document 174. It's just the subject, I think, should have been redacted, that's all. So if you look at Bundle 14, Volume 2, Document 174, page 655, you'll see it's an email on the 3rd of January 2020 to you about some of the issues, albeit not the SCI, but some of the other issues in your investigation, or something about your investigation. Do you know what the context of this is?
Well, I'll just read this.
If you look over the page, you might see it's actually about the Duty of Candour matter.
So
maybe it's not relevant to this point.
So looking at the timing of this email correspondence, which is at the end of December, beginning of January
2019, 2020.
2020.
Do you think this is mainly about the Duty of Candour?
I think so. The email says, I enclose what I hope is the final draft of the reply to Professor Cudahy. And therefore, I'm presuming that this email is related to the letter that went from Dr. Armstrong to Professor Cudahy in January 2020.
Well, maybe that's not relevant then.
I'm presuming that's the context of that.
But she also explained her position to Rachel Green and Rob Gardner when they met her. And so on this occasion, this is the 5th time she's been asked to repeat her concerns. Do you think it's reasonable to assume that she's changed her mind if she doesn't reply to that email?
I'm not sure I can comment on that.
Well, the reason is that what's happened is that, for reasons that I absolutely understand, there's been a pandemic. During the process between you starting a review and you ending a review, at some point the SCI was finalised. And the final draft has been copied to other people, including Dr. Inkster, and she hasn't cut in and said, no, I still disagree. But she's raised it 4 or 5 other times. And you seem to be relying in your statement on the idea that she sort of approved the final version. Is that what you want us to understand?
No, I'm not relying on that at all. As I said, the exam question I asked myself was whether due governance was followed in terms of the SCI, because it is recognised in a small number of SCIs that there is disagreement, and sometimes that disagreement can be difficult, if not impossible, to resolve. And the commissioner of the SCI at the end of the day has to make a call on that disagreement. And on this occasion, they spoke to the head of clinical governance, who felt this was an appropriate way to go forward in terms of the revision of the terms of reference.
So effectively what you've done with the SCI is you've checked on the person you checked. You've reviewed a review.
No, I'm not sure.
Mr. Crawford did the review, and you reviewed that. Or is that being a little bit harsh?
Yeah, I'm not quite sure that's the case, because Mr. Crawford won't have been involved with writing the SCI.
Right.
All he's been involved with is the commissioner has said, this is the process that we're going to follow. Does this seem reasonable? And he said yes.
I see. Well, let's move on to the duty of candour incident, which is on page 94 of bundle 27, volume 6. Now, I don't want to take too much time with this, but in essence, I've got three questions. The first is, did you interview or speak to Professor Cudahy about what he said happened at the meetings?
I did not. I've never met Professor Cudahy.
I presume the same would be true for Jamie Redfern as well. You didn't speak to him.
I did not speak to Dr. Redfern. As I said at the beginning of the review, I didn't set out to interview lots of people for reasons that I've stated here.
Yeah, and so there is a lot of correspondence between Professor Cudahy, Mr. Redfern, John Brown, Jane Grant, and Jennifer Armstrong in the second half of 2019 into 2020. And indeed, they meet on the 12th of November, Mr. Brown, Dr. Armstrong, and Jane Grant and Professor Cudahy. Would you have seen that correspondence, apart from the letter you were involved in writing, would you have seen that correspondence as part of your review?
No, so the correspondence I saw as part of the review was the correspondence from Dr. Armstrong to Professor Cudahy in January 2020, and then the subsequent correspondence between Jane Grant and Professor Cudahy, I think, which was from the February, and I think I've quoted that at the beginning.
I think
of
you
the
have,
review.
yes, you've mentioned those two.
And subsequent to that, in the bundle, there's also a letter from Jane Grant to Professor Cudahy in September of 2019.
Yes.
I've seen that as well, but I hadn't seen that at the time I did the review.
Right, you hadn't. So the only, as it were, Cudahy correspondence you saw are the two documents you've listed in the review. Now, do you feel in any way that not having spoken to these, to particularly Professor Cudahy, but also Mr. Redfern, and seeing the correspondence where he describes repeatedly what happened, in some way undermines the effectiveness of your review? Or is that being unfair?
I found this aspect of the review very difficult. And again, part of the reason for that was the fact that I was writing it, in May or April and May of the next year, as a result of the delays following the COVID pandemic. And I can totally understand the perspective of Dr. Inkster, where she felt that her ability to communicate freely was being undermined. Again, I go back to the exam question I asked myself, was this simply poor communication, delayed communication, and inadequate communication, or was it any deliberate attempt to undermine Dr. Inkster? And that was the question I tried to ask myself.
And which side of that split did you come
I came down on the side that this was cock up rather than conspiracy, if you don't mind me using that kind of phrase, that this was just poor communication, delayed communication. And I think the emphasis is on the delayed communication. I think often in healthcare, we sometimes delay communication because we want to get the communication perfect or because we want all that information to be available. And in this circumstance, there was clearly the need to try and get the typing of the coloni available in order to provide the optimal communication. And there was also the concern about confidentiality, because there was more than one parent available here. And the impression I got here was this wasn't any malice, this wasn't any deliberate attempt to undermine Dr. Inkster. This was just poor and delayed communication in the context of all the things that was going on. That's the side it came down on, but I suppose at the end of the day, that's a judgment.
Look, I appreciate that. The problem that I suppose at a high level that there is with that is that the inquiry has been looking into the Mycobacterium cheloni infections, and the first thing that's notable is that in 2018, in May, when Professor Cadet's daughter has her infection, and it's reported to them in June, it doesn't end up appearing on the timeline from the oversight board, and it's not properly reflected in the list of blood sample infections that the case notes review have, and indeed it's not properly described in the data set we have. Now we've worked out it's been described at a slightly higher level within its genus as a bacteria, but there's a sort of confusion there about whether it was properly noticed at the time. It's reported by Dr. Inkster to HPS in an email as part of the gram-negative outbreak. It doesn't have its own red high art. The inquiry has got a full set of all the bloodstream infections for the hospital back to the time it opened, and there's seemingly another case in 2016 in the data set. So do you see how it might look? There's the two questions that seem to be that Professor Caddy wants answers to. One is, why did an investigation not follow his daughter's infection that might have prevented the subsequent one? That seems to be a quite good question to ask. And the second one is, well, why did you allow the water system to get to the point where the infection might have occurred for her? And so do you see how, whilst it might be a cock-up, it looks suspicious to the professor? Do you appreciate that?
So I think it's entirely understandable that if communication is poor or communication is delayed in the context of what you're describing, I can completely understand the perspective of Professor Cuddy in terms of what you're saying. Yeah.
So what I want to do is to go to your statement, please, which is on page 174 of the statement bundle. And you note in the second half of this page that at the bottom of the page, however, the report clearly notes the communication during this episode was suboptimal, and the chief executive of the health board has apologised for poor communication in a letter to the parent. Where does this poor communication happen? Does it happen at the time of what we are referring to as the duty of candor incident, or does it happen in the follow-up?
I'm not sure I can be specific about that.
Well, you carried out a review, that's why I'd ask you. So, I mean, you've described how there's been poor communication. You've identified that what you frankly describe as a cock-up rather than a conspiracy. Do you see that as happening at the time that Professor Cadder was hoping to receive the information originally in 2019, or was happening later as you see it, people were trying to get the communications right? Where do you see that event happened?
I'm not sure necessarily there is one event, but I can see that communication. I think what I'm saying here is that communication was poor, but I'm not being specific in terms of one particular point in time.
Right. Now, what I want to do now is just to touch on to 3.3 at page 96 in the bundle 27, volume 6. You've already explained 96. Sorry, page 96. Yes, you've already discussed, and you've sort of corrected me on what you thought the issue was, and I won't go back to that. But are you obviously you make reference to the original Water Technical Group being set up in the early part of 2018 by Dr. Inkster. Does that ring a bell?
Yes.
Yeah.
I've got that. As I said at the beginning of the statement, I did speak to Mary Ann Kane regarding that, so that's where I've got that information from.
Yes, but that was just very briefly about the original setup.
Yeah.
Because we've had evidence from a number of people who attended the Water Technical Group, that one, the one that started in March 2018, and you don't get the impression that they misunderstood what the purpose of it was. It seems to be a technical offshoot of an IMT to try and get to the bottom of a particular problem that they were facing. Do you think it would have helped to speak to other people that attended the meetings?
So again, I get back to specifically what the ask was here. The ask was Dr. Inkster flagged a specific action that she felt hadn't been taken forward, which was related to the chlorine dioxide, and reviewing all the minutes, it was clear that that was not correct, and it had been taken forward. And then she talked about the Water Technical Group making decisions that were not minuted or discussed at the IMT. And I suppose that gets back to the link between the Water Technical Group and the IMT. And I think the point I was making in the review was that being chair of an IMT is a very, very challenging process. You have to take views from across the meeting, you have to look at hypotheses, you have to take evidence forward. And if you're going to have a subgroup of that meeting, then one of the best way forward would be to have the chair of the subgroup reporting regularly through to the IMT, rather than take it forward yourself, because then you can question, then you can clarify, and then you can get assurance that things are being taken forward. And if the chair of the IMT is also the link to the Water Technical Group, the governance, that's where my governance hat comes in here. So whenever I've been involved with meetings in the past, and then you've got offshoots of the meeting, I think it's really important as a chair of a meeting that you're not then charged with being the link for that off group as well, because as chair of the meeting, you can't provide assurance to yourself. If you follow me.
I do follow you. The final thing to say about this, I suppose, is we've had evidence about a debrief meeting happening at the end of May 2018, following what was at that point thought to be the end of the water incident. Unfortunately, it wasn't. But there was a debrief meeting chaired by a nurse consultant from HPS, and there's a detailed minute, and there's a report producing that, and no one who's attending that debrief seems to think there's been a problem with the water technical. Did you look at that debrief or speak to anyone involved in that?
I didn't see that debrief, but again, I would add that so if you're looking at structures of meetings, it's not good governance to have be reporting to yourself.
So the final thing to do is just go your summary on page 101, and we've already discussed the use of the word corroborate, and I appreciate your comments earlier, but in essence, what you seem to be saying is you didn't deliberately set to interview additional people. We've discussed that in the second paragraph, that Dr. Inkster raised issues with Dr. Armstrong, and these concerns have been explored in detail, and the review is unable to corroborate the specific concerns. And are you effectively saying it's not so much that you couldn't corroborate them as you didn't ultimately agree with them? Or is that putting words in your mouth?
No, not necessarily. So, as I said already, taking Dr. Inkster's perspective, particularly for the first two issues, I can totally understand where she comes from. And what I tried to go through was to go through things logically and systematically, looking at the governance, where the appropriate governance was taken forward for the SCI, and come to a viewpoint about the communication. I suppose in retrospect, if I'm looking back and rewriting this review, conscious this was looked at, this was being written through the lens of May 20, of a year and a half later. I probably would just leave out that sentence in itself and leave the narrative to speak for itself. Yeah.
Right. My final question goes back to, it's about governance. And since you've done all this work and you're now a medical director in another health board, it seems a good opportunity to ask you a question on governance. The meeting of the 20th of August that we discussed earlier.
That's the one in the GRI boardroom.
Yes.
Okay.
So I put you on the spot and asked you some questions about what you did in a meeting that you weren't the main player in. You were the deputy medical director in a meeting chaired by the director of public health, with the medical director present. How do you answer this challenge about governance? How do you govern successfully a situation where senior people, more senior than you, senior people in the health board, are doing something that probably doesn't look fair? It must be quite difficult for someone 3 weeks into the job to put their hand up and say, we shouldn't do this. Would you accept that's a reasonable defense from your point of view?
I think that's reasonable, yes.
Yeah. How do you regulate and govern the senior professional and managerial heads of an organization like a health board? What is the check on them? Since they control the provider of information to the board, and they can intervene when governance justifies it in matters like the SCI and duty of candour, who governs them?
So the governance of the executive sits with the board and the non-executive members of the board. And so good governance should be that the board requires to be assured that the executive is performing its role appropriately. And that's, so the governance of the executive sits with the board and with the non-executive members of the board.
Now, this may be true for other types of organisations as well, I accept that. But in a health board, how do the non-executive members know they're being told everything that they need to know?
By ensuring that papers that are coming to the board, and particularly to the sub-levels of the board, where, at the level of corporate governance, staff governance, rather than the board itself, but the meetings that are chaired by non-execs, to make sure that the papers there are covering all the relevant issues and are covering that broad range of issues that they would expect.
So you wouldn't feel that there's a slight issue of the senior executive members of a board having significantly more information than the people who are supposed to be supervising them, the non-executive members?
I think the executive members of the board will always have more information, and it is, yeah. So I'm not sure I can say more than that.
Because I suppose that the final comment to make, a question to make before we have a short break to see if there's any other questions, is I've obviously asked you questions about the 20th of August, but you're not the first witness who this inquiry has asked, why didn't you do something? Why didn't you ask that question? Why didn't you intervene? That has been a repetitive question we have asked of many witnesses. And the answers that we get are not dissimilar to your effective answer. But how do you ensure in a health board, particularly a big one, that people are not just assuming that something's been done? They're not just assuming that someone else has got it under control, that someone else has thought about the ethics, that someone else has thought about the ventilation, whatever it is. how do you stop people just assuming their colleagues are doing the thing they think their colleagues are responsible for, and their colleague either doesn't care or doesn't think it's their job?
So I think what you have to have across an organisation is a broad range of structures where folk, employees, colleagues, doctors, nurses, healthcare staff, all staff can raise concerns. And that can exist across a broad range of areas. So you can raise concerns through a management structure, you can raise concerns through a clinical structure, you can raise concerns through a clinical advisory structure, or you can raise concerns through statutory structures like whistleblowing and things like that. And therefore you have to ensure that there are appropriate ways of raising concerns across an organisation, such that if things are not being presented, are not being taken forward at a higher level from the level that you're functioning at, then there's an opportunity for those concerns to be raised accordingly.
Because the problem with that might be that the SCI incident that you reviewed and the duty of candour incident that you reviewed both involve somebody, a relatively senior member of staff, wanting to say something or reach a conclusion or make a statement about an area within their expertise, but the governance structures eventually deciding that a corporate position will replace it. Is there not a risk that if that happens, people will just keep quiet, they won't speak up, they won't raise these issues, and their mistakes will be worse?
And that's why you have other mechanisms of raising concerns that don't necessarily go through the corporate structure. So, for example, from a medical perspective or from a clinical perspective, there's the clinical advisory structure, which is a statutory structure that's within health boards. And then, as I said already, there's a whistleblowing process as well. So, and that whistleblowing process can go out with the health board as well. And therefore, it is ensuring that there are other mechanisms to raise concerns if an employee, be a clinician or what, feels that their legitimate concerns are not being taken forward accordingly.
So given that the meeting on the 20th of August was chaired by a member of the board who's also the whistleblowing person and was attended by the medical director, who's the senior clinician, they are the people where that parallel structure ends up as well. It's the same people. So do you feel on reflection that you could have done more to ensure those events of the summer of 2020 in August were fair to Dr. Inkster?
I'm not sure.
Because you've told us that you wouldn't have been happy if it had happened to you. So what should someone do? What should a new doctor do if they're in a meeting which they're invited to, which doesn't say what the invitation to the meeting is about, turns out to be about something different, where they all want to talk about a colleague who isn't there and make a decision about them? What should a junior doctor who comes to you do in that situation? What's your advice?
So I have been faced with this situation in the past, and if they feel that their concerns are not being recognised, then, as I outlined, there are various structures to take that through, and that could be the advisory structure, that could be the staff side structure, or your union, or it could be the whistleblowing process.
Did you do that at the time, though? Did you bring this up with Dr. Inkster, or Dr. Armstrong, or Dr. Kasek?
With respect to what?
The fact that the meeting was being held about Dr. Inkster, to which she had been invited with an invitation that didn't tell her what the meeting was about. So did you bring that up at the time?
So I get back to I'm not aware that I don't recall seeing that email that described what the meeting was in the first place, and therefore I'm not sure I take.
Well, how did you get to be in the meeting? How did you know to go?
I get invited to meetings in various different ways, and that does include meetings being put in my diary, which I then find out I have to go to by my PA, or alternatively, I'll have said, yes, I'll go to that meeting. I just don't recall seeing that email.
Well, I'm grateful for your time. I don't have any more questions at the moment, Lord. Maybe my colleagues want me to ask further ones.
Dr. Deighan, as Mr. McIntosh has indicated, I need to know if there's any more questions in the room. Now, we should be able to find that out in the next 10 minutes. So could I invite you to return to the witness room, and I hope I can bring you back within about 10 minutes to confirm whether or not there are any further questions.
Will do, my lad.
Well, I have a trio of questions.
Trio of questions. We have perhaps 3 questions, Dr. Deighan.
And one other thing I didn't do, Dr. Deighan, is I didn't take you to Appendix B to your report, which starts on page 102 of Bundle 27, Volume 6. And yeah, there we are. So that's the note. So this interview note, is this, as it were, a text that you received, Dr. Green, or your summary of what she said?
This is what I've received from Dr. Green, and I've just added Appendix B so I could include it as a separate reference
Right,
as part of the review.
Fine. I'm focusing on the duty of candour incident. Over the page, she describes that she was told, second line of page, by the lead nurse for infection control that she was not to tell X this detail. Did you speak to the lead nurse from infection control?
No, as I said in my response, I didn't seek to interview lots of people as part of this review.
Because what I'm concerned is that what I've read of your report and what I've seen in your statement and what I've listened to you say, I don't get the impression that you actually know what the lead nurse for infection control would say if she was asked anything.
So I tried to look at the information that was available in the letters where Miss Grant clearly apologised for the poor communication, but outlined that this was not meant to mislead or withhold information. It was just poor communication.
Yes, but whatever the terms of reference of your review, the point that's being made by Dr. Inkster to Dr. Green in a meeting that takes place at your request is that she was told this thing by this person. And it's this thing that is the heart of her concern there's been a breach of the duty of candour obligation. Do you appreciate that it seems strange that you wouldn't try and find out what the lead nurse for infection control, what her take on these events are?
That's a legitimate criticism, yes.
And in fact, it rather undermines your conclusion, doesn't it? Because if your conclusion is this is not a conspiracy, but a series of unfortunate events, if the principal allegation is true, then it wouldn't be a series of unfortunate events. It would be an actual breach of a duty of candour. But you didn't go and find out whether this allegation is true, did you?
That's a fair point, yeah.
Right. In the summary section, the last paragraph, where Dr. Green makes the fair point, this is obviously only one side of the story, and others would need to be interviewed to get a balanced view. And perhaps this will come out in the other many processes that are currently ongoing. Were you provided information of any such process that did produce the other points of view?
Sorry, could you just ask that question again, Mr. McIntosh? It's entirely my fault. We're looking at
what I'm asking is, in the first sentence of the last paragraph, this is obviously only one side of the story. I'm assuming this is Dr. Green's voice. And others would need to be interviewed to get a balanced view on these. And perhaps this will come out in the many processes that are currently ongoing. Now, that statement would appear to have been made in early 2020. You wrote your report 18 months later for understandable reasons. Are you aware whether any of the other processes that you saw and had access to obtained this other balanced view from the other people?
So the only sources I've got, I've listed at the beginning of the review in terms of, you'd have to go back to my review and page 1 of my review.
So we go back to page 91. Let's look at what they are. 91. Yes, sorry, carry on, please.
Yeah, so these are all the sources that I used in terms of the review. I couldn't answer your question in terms of any other information subsequent to that. As I said, I left G&C almost 2 years ago now, and haven't really been involved since January 2023.
So if we just go to your conclusions on the duty of candour incident, which is on page 95. In the final paragraph, you've written, in summary, it is clear that this was a complicated scenario that involved communication with more than one family, with the need to maintain professional confidentiality, and communication during this episode was suboptimal. So you don't know what the whole communication was because you didn't speak to the people who did the communicating.
That is correct, but it's clear from the information I had that communication during this episode was clearly suboptimal.
Yes, but what you can't say is that Dr. Inkster is right or Dr. Inkster is wrong about what she was told by the lead nurse director for infection control.
Yeah, that's correct, yeah.
Right. Now, the final thing is that you wrote this report in 2021. You've explained how it took more than a year because of the pandemic. But by the time the pandemic hit, or we were all beginning to get worried in January of 2020, the best part of 6 months had happened. Do you appreciate that this might have caused some excessive distress and concern to the family to take this long to produce letters and meetings and information after repeated letters from the professor? This took a long time, and that will cause extra distress.
Are you talking specifically about this review?
No, I'm talking about the whole process.
Right.
Because you've reviewed the process, and in the period between the incident happening and you being asked to do the work and Dr. Green speaking to Dr. Inkster, quite a lot of time passes. I mean, a good 6-7 months. Do you appreciate that might have caused that time might have caused some considerable distress to the family?
My understanding that you already mentioned that there were multiple pieces of correspondence going to the family in that intervening period, including a letter from Jane Grant in September of 2019, and then a letter from Dr. Armstrong in January of 2020, and a further letter from Ms. Grant in February 2020. So,
do you feel that's a sufficient time?
I'm sorry, I'm not sure that I'm following.
So the incident happens in the summer of 2019. The alleged incident which Dr. Callaghay is talking about happens in the summer of 2019. It takes until February of 2020 for the final letter of that sequence you've just listed to get to them. Do you feel that is an adequate amount of time? Could it have been quicker, or is it an understandable amount of time to take to resolve these issues?
So if it is taken until February 2020 to resolve the issue, then I think that would be understandably a very an unhappiness at the length of time. But I wasn't involved with the communication with Dr. Cunningham apart from that letter in January, and therefore I'm not aware what communication was taking place with Professor Cuddy during that period of time.
And I suppose the final question then is that you did this review with its particular purpose that you've described. Do you feel that the carrying out of this review will have advanced matters further for the families involved when they find out about it? Did it help from their point of view?
So the review, as I understood it, was to look at the three issues that Dr. Inkster has raised. I'm not sure necessarily it can be looked at in isolation from all the other information.
So you have, so from the point of view of the impact on the families about who are the subject of it, you see it as part of a group of responses from the health board.
This review was requested by Dr. Armstrong and was, a response to Dr. Armstrong's request. It wasn't specifically designed to respond to requests from families and parents involved.
So it's more of an internal document in that sense.
That was my understanding of it, yes.
I don't think I have any more questions, Morris. Thank you very much.
Dr. Deighan, these are the questions that you're to be asked, and that means you're now free to go. But before you go, can I thank you for your attendance? Can I thank you for the preparation of the written witness statement and the work that will have gone into that? I'm grateful for that, but you're now free to go. Thank you.
Thank you, my lord. Thank you.
Lord, the next witness is tomorrow morning. It's Mr. Bratty, and that will be taken by Mr. McKeever. And then tomorrow afternoon is Miss Pritchard, and I'll be returning for Miss Pritchard.
Very well. We will see each other, therefore, at 10 o'clock tomorrow. And can I wish you a good afternoon?
Please stand.